I just wanted to thank you all for your great talks, and I felt it was important when you were here just to discuss a couple of things. And instead of talking about facts and things, I thought it was good to stimulate a discussion between you experts and, of course, you experts in the audience. And in my talk, I just wanted to stimulate that discussion. Whilst I don't see the presentation, which is probably not a problem, I think one of the issues really is what do we think about indications? Is there a need for indications really? And how can I just move on? Is that... Oh yeah, here we go. So, which one? Oh, no, not working.
Do you do valves?
Yeah. Das ist dieser hier eigentlich, ne? Dieser da. Okay, here we go. So basically it's about indications. So it was, are there clouds on the horizon? So that was the actual theme of my talk. And that's a photograph which I've taken at the tip of Bornholm. And it shows you a very nice and beautiful dramatic picture of a very cloudy skies. So what are areas of uncertainty which we have? And of course, I felt indications would be an area of uncertainty. Then the question, do we pick the right outcome parameters in our studies, or is everything clear? The other thing I wanted to talk about is there time for precision medicine? And what is your feeling, your thoughts about that? And eventually, what are future developments? So basically indications, so is there a need for discussion? And of course there is a need for discussion because we do have the problem of lifetime management too. So our colleagues in the morning session have talked about lifetime management and lifetime concepts. And this is a very interesting study which has been done by our National Registry of Congenital Heart Defects. And it shows that patients at the age of 30 already had to undergo 5 repeat interventions within the outflow tract and the pulmonary valve. So of course there is a need for discussion about indications. So we can achieve enhanced biventricular efficiency with transcatheter pulmonary valve. We can achieve enhanced biventricular efficiency by improved LV filling properties and improved ventricular-ventricular interaction. And is there anything that we talk about or that we should discuss about the timing? We know that there's like an egg timer. So once we place a new valve, it will degenerate. So that's for sure. So at the end of the day, we can help improve the longevity of the valves by, for instance, pre-stenting, or we can also do repeat valve implantation in the case of valve failure. But all in all, I think there's a need to discuss indications. So, Shaq, what's your take on that?
Well, the obvious one is we're currently using MRI-based criteria, and the question arises as to whether what we're using is whether that's correct, or whether it's too late or too early. And there is still, sadly, no universal agreement, because some people say, well, the end diastolic of 150 is correct. Others say it should be lower than that. And there are more recent others who say that is still too early. So we haven't got the answer for that. I think we're probably about the right area. But at some stage, if the technology was much better, then we would intervene earlier.
So Matt, what do you think?
Yeah, it's a great question, and it's really realm of philosophy more than anything. You see, we rely on MRI, but I think it's nonsense, to be totally honest with you. I mean, 150 is basically a random number that was picked from an observational study back in 2003, 2004, when MRI was starting to mature, looking retrospectively at 17 patients in Canada. Actually, it was 170. And it became 150 because 150, I think, was easier for people to remember. And then what happened was, then the MRI guys got a hold of this, and I love the MRI and the imaging guys, I love it. But what happened was they started tripping over themselves with guidelines. The European guidelines were 200, the Canadian guidelines were 180, the American guidelines were 150, and there was somebody somewhere around 170. And we just started talking about volumes. So yes, we have to track these patients. The reason we're tracking these patients is that at the time, we didn't really have a good minimally invasive way to do this, number one. And now we have that. Now the question is, We've demonstrated we can do it. We can do it safely. We can do it with minimal risk. Now the question is, how durable is this intervention? Because if you can do a durable intervention in a 15-year-old and spare them 15 years of regurgitation, and now they're 30 getting in case 2, then getting the second procedure, that's the thing to do. Your patients, you got to think of them from infancy or fetal life, as Jack Rychek would say. They should all live to be 90. Your goal should be to get everybody to 90 years old with as healthy a heart as possible, with the least amount of interventions over time, both surgeons. So that, like, philosophically, that's the goal. So, sorry to go on and on. But the MRI, like just relying on MRI criteria or CT criteria, I think these numbers are completely artificial. I'll tell you the number from MRI that I do like, though. I like RV-LV ratio, okay? Because if somebody comes to you and their RV is 150 and their LV is 60 as an end diastolic volume, you know, you're more than 2 to 1. So if you had any other part of your body that was suddenly twice the size as the other, you would probably see a doctor about it and treat it, right? That's probably, so if your left hand was suddenly twice, you'd be like, somebody fix this. You wouldn't wait on it. And now that we can do this safely, now we're proving with all these technologies that we can do it safely, you're moving into the realm of how durable is this? And that's why I'm saying what we can do is get there, we can anchor, we can seal, we know it works, the heart remodels, we just need leaflets that are going to be durable and not prone to infection. I'm going to stop. Sorry.
No, that was really, really good. So now when we move on to the outcome parameters, Stefan, so do you think that we pick the right outcome parameters? You've demonstrated the outcome parameters in the large registry, so combined endpoints of death, reintervention, the need for reoperations, and endocarditis, for instance. Do you think we are spot on with the outcome parameters for our studies here?
Well, I think that's what we can do in the moment. So what we're heading for, I just was thinking about by the presentation, what are you heading for? So do we like to have in our patients the biggest valve they can have, for instance, because the Harmony and the Altera and the Venus are different approaches. I mean, they get really big. So is it our intention to bring the patient to such big valves, which are completely out of proportion of normal? So, I mean, 30 millimeters, 32 millimeters transannular RVOT patch is not normal. That's what you say. So, and then the load is on the ventricle part. So the ventricle should be supervised by that. So we should more look for the ventricle because that's the one that's the motor of life. I mean, he should last for 70, 80 years, as we heard today. Also in the adults, they can get to that age. And so I think really we have to look on that. So valve durability or valve expectancy is not the only parameter. We should screen the patient for dysfunction of the ventricle, much higher volume load than we should expect. And the question would be to our surgeons. I mean, transannular patch, how long can we be reluctant by treating that, or should we approach it earlier? And I think, again, we come to the point, valve durability. So this is the way. So I think we look for the right, which we can do, but maybe we are still on the wrong path.
Thanks, Stefan. Yeah, Sabine, please.
Yeah, so maybe I can step in, Sabine Klaassen from Berlin, for outcome parameters and for infectious endocarditis. And our National Registry for Congenital Heart Defect in Germany has already been mentioned. And the question actually is outcome parameters on the long-term perspective. And what we did, we looked at all the patients in the registry who got a PVR, surgically or interventionally, until December 2017. And actually this, it mattered. The outcome parameter for endocarditis, or endocarditis was more frequent in the valves that were made from jugular valve tissue. So no matter if it was surgical, like the Contegra valve, or Melody valve interventionally, the risk was increased. So this was a median follow-up of 10 years. So, and you were asking before, does it make a difference what we use on the long term? So this is just data that might be interesting to you. And of course, I'm very impressed by all the advances which were made, but I think we need to look at the outcome on a long-term perspective and with epidemiological data as well. So what is your perspective on the studies? Are you planning the long-term studies and for outcome? I guess so, but maybe you can give
Thanks a lot
Yeah.
for that comment and question. Shakir.
Well, for the outcome, I'll let Stefan, because he has the data, but he can answer that. But what I was also going to say separately was Stefan said in a very diplomatic manner that it was all the surgeon's fault.
Not.
No, Stefan.
We could actually show that it makes no difference, the method of...
Yeah. No, what I was going to go on to was if the patients that we're dealing with self-expanding valves have valves of greater than 30 millimeters and we're implanting self-expanding valves at the age of 10, 15, 20, are those patients better off going back to the surgeons and us asking them to put a better valve in place at 30 or thereabouts, depending on the body surface area, which then allows a much better valve to be developed in the future, 10, 15 years down the line, which might then last them up to 90 years of age. That was what I was getting at. No, I wasn't blaming.
But Sabine, I think your study, the study which was done with the National Registry, it's the same. You look retrospectively in the area what is implanted as a conduit. So these are different anatomies. I think we talk about transannular patch and conduits, and conduit lifespan is really different, as we can see also, because most of the patients we are treating with transcatheter valves also have conduits. So I think there's no holy grail, or what's it called? Gray.
Yeah.
Sorry. But the question is really what is the risk of the patient and the expectance of a homograft in comparison to Contegra and the Hancock conduit. And we have also done in our center mechanical pulmonary valves which have completely struck and completely thrombosed. So I think there's no one. So we have to have a compromise on that part. And the question would really be, what we're heading for in regard to valve diameter, because if we are at a recent point, like if the venous is inside now 30 millimeters, what is in the future 10 years later? What can we do, Shek? What do you think what we can do with a patient come back to you 30 venous inside 10 years ago?
So theoretically, I mean, that's a very good question. Theoretically, it should be possible to put another straight valve, self-expanding, similar diameter, 30, and carry on doing that every 10, 15 years and avoid any further surgery. And ultimately, that valve is going to get down to about 26, 28 millimeters, which again is likely to be okay for that particular patient. So we can predict that sort of thing, but a lot of it really just depends on how the valve leaflets behave in the future.
Yeah, I think we need basic research actually on the tissue. And there will be more talks tomorrow, so...
Yeah, thanks. Now we've got Achim with the surgical view, I suppose.
Of course. Shaquille opened the battle and I have to respond. First of all, I didn't fall asleep. I didn't give you the chance.
I was watching.
I know you would. From a surgical point of view, I miss a surgical talk with responding to pulmonary valves. There's new techniques. We talk about valve sparing techniques and avoiding transannular patches, which is bad. From our side, I would say we would look on the function of the ventricle. We are not afraid about pulmonary valve replacement, not any longer. I think we have precautions. We use material that eases up the reoperation. But if you can do that, we are very happy, of course. But the bottom line is to restore and maintain the function of the right ventricle in terms of pressure and volume load. I think that's the outcome. And if you normalize that, that would be appreciative. And other than that, there's no much numbers. I like your numbers. It's because everybody has an impression of, well, it's two size normal or two size, double size, the left ventricle. That must be not good. And I totally agree to that the numbers you sometimes get from MR are totally random sometimes.
Thanks a lot. So another area would be precision medicine. So can we offer the perfect match? And this is probably something which you already touched upon. So maybe if you allow me, I would just go on to the last thing, which would be future developments. So one of the questions was that Stefan, you brought up was in terms of MDR. So can we keep up with the transcatheter valve technology, or let's say overall, medical material? So what's your thought on that? So because you brought up that question.
So you mean if we get this material for a treatment? I think the development for the adults is much faster than we see it for the pediatric population. So I'm a little skeptic that we get the same approach, but we have to keep an eye on that. And as I think Professor Falk did in the morning said, we have to be interdisciplinary working on that. And I think that's a really good way to see that this technique also goes to our patients. And hopefully, yes, I see a lot of restrictions now, really, actually. And that is my concern in regard to what we can do and what we would like to. And I think Czech is in a much worse position than we do, but in Europe, sorry. But honestly, yes, it's a big hurdle we have to do, and we have to get over that. And I think we hopefully, in a couple of years, can maybe treat all of patients still.
So, Shaq,
if I could just add, firstly, the UK has made an absolute mess with the Brexit, because now they're forced into now that we're forced into having, for political reasons, not even the CE mark approval, but we've got our own UK CA mark. So companies are going to have to get CE mark as well as UK CA mark, so they're going to have to pay twice. The European Union has made a real mess with the MDR changes, and essentially they've taken us, that's UK included, Europe, into FDA of 30.
Thank you for that, by the way, regulatory agencies.
So I'm blaming.
we've totally benefited.
I'm blaming the Americans for all this. The FDA 30 odd years ago, it was impossible to get anything done. Now they're doing what we were doing in Europe in 1990s. And so this MDR is going to have a huge impact on companies, which are going to have to pay twice, Europe and UK. The other thing is big companies that are related to dealing with adult patients, they can afford paying twice, and also the costs that are involved in notified bodies evaluating their product. Pediatric cardiac companies, the costs are so prohibitive, they're gradually pulling back on their materials. And so we're going to be, come June 2024, or 23 for Europe, I think it is, and 24 for UK, we're going to have huge problems with equipment. And so that's going to be your, you can dream about valve technology and research and development, but it may be impossible. We might have to rely on the Americans to help us with that.
That's an important point. So,
that's right.
So Matt, so the question I would like to ask you is, so we've got Boris with us here who works on tissue engineering approaches to transcatheter valves. And there was also a very interesting US study even on fetal interventions and fetal transcatheter valve replacement. So what's your, let's say, American glimpse into the future?
Yeah, I mean, that is the holy grail, to borrow your term. It's all about the leaflets. We figured out how to anchor and seal and get there, but now we have to focus on minimizing the risk for infection, minimizing the risk for clotting, minimizing the risk for early degeneration, and all of that is beyond the ability of a simple plumber. So we need actual scientists, we need sort of material scientists focused on leaflet durability. And I would say, the companies, if you go back a slide, every single one of those devices that you have on there are applicable to congenital heart disease. And what we have to do as congenital interventionalists is drag these things to our patients. Because there is no money in creating an Intrepid valve for the single ventricle patient with AV valve regurgitation, but I have patients that would benefit from it. So we have to get through this regulatory mess, and we actually have to work with the companies to facilitate dragging these into our patients, because they're never going to do it on their own because there's no money in it. It's a loss. It's a giant financial loss. But along with that, as you look at this, every single leaflet there is, in every single device, is going to suffer the same fate of every other tissue-based leaflet that we know about and have known about for 70 years. So the future is what you're working on and what they're working on here with developing materials that are going to be more durable and more infection resistant, in particular, clot resistant in particular.
I won't spend too much time on this, but a company that has one product may have to pay 150 or 100,000 euros to get the process started for evaluation. A company that has 20 products, you can multiply that by 20, and that you can see where pediatric cardiac companies are going to be looking at their financial impacts and say, well, forget this, we'll stick with the adults.
But I think we have to be and keep optimistic. And that would be my outlook. So there are clouds on the horizon.
Johannes, I was being optimistic.
Thank you. No, so that's a cloudy sky, but it's just about to give rise to a very sunny day. And so that would be the optimistic outlook. So once again, a huge thanks to all of you experts. I think it's been a great session, and thanks to you. Thanks.